Welcome to Cardio and News by Dr. Caroli. Today we've got Susam and Tom from Massachusetts PTO University joining us.
Great to be here.
We're going to do a deep dive into a really interesting new paper, one you actually flagged for us, relevant for practicing cardiologists.
Absolutely. Caught my eye straight away. The title is Effect of Colchicine on Coronary Plaque Stability in Acute Coronary Syndrome as Assessed by Optical Coherence Tomography, the COLOCT Randomized Clinical Trial.
Right, published in Circulation this year, 2024, so it's hot off the press.
Pretty much.
And our mission today is really to pull out the key insights, especially around what colchicine does to these coronary plaques in ACS patients, specifically looking at these OCT images.
Exactly. We want to give everyone listening a clear takeaway on the findings and what they might mean for patient management.
Okay, so before we jump into this study, just briefly, colchicine isn't entirely new in this space, right? We've seen it pop up before.
No, definitely not. I mean, we've had trials like COLOCT and LOTOCO-2 showing it can reduce cardiovascular risk in patients with coronary heart disease.
But those were more about clinical events, outcomes.
Right. The piece that's been maybe a bit missing is direct proof of how it's affecting the plaques themselves, what's happening structurally.
And that's where COLOCT comes in, using OCT to actually look inside.
Precisely. That was the specific goal. Use this high-resolution imaging to see the impact on plaque characteristics.
Okay, let's dig into the how. What was the setup for this trial? The methods?
So it was a prospective trial, single center over in China, randomized, double-blind, placebo-controlled, the gold standard design, really.
And who are the patients they included?
They enrolled 128 adults aged 18 to 80. The key criteria were that they had ACS, acute coronary syndrome, and crucially, OCT had to show they had these lipid-rich plaques.
Lipid-rich meaning what specifically?
The definition they used was a lipid pool arc greater than 90 degrees on the OCT image, so a significant fatty core.
Got it. So 128 patients with ACS and these specific plaques, then what?
They were randomized 1-to-1. Half got colchicine, a low dose, 0.5 milligrams daily.
And the other half?
Placebo. And this was for 12 months. Importantly, this was on top of all the standard ACS treatments.
Right, so everyone's still getting their dual antiplatelets, statins, beta blockers, all that usual stuff.
Exactly. Colchicine or placebo was the only difference between the groups.
Okay, so the big question, what were they primarily measuring? The main endpoint?
The primary endpoint was the change in the minimum fibrous cap thickness, the FCT. They measured it with OCT at baseline and then again at the 12-month follow-up.
The thickness of that protective cap over the lipid core.
That's the one. A thicker cap generally means a more stable plaque, less likely to rupture.
Makes sense. Were there other things they looked at, secondary endpoints?
Oh, yes, quite a few. They looked at changes in the average lipid arc, so the size of that lipid pool.
Did it shrink?
Well, that's what they measured.
Yeah.
They also looked at macrophage accumulation, using the mean angular extension on OCT as a marker for inflammation within the plaque.
Okay, inflammation.
Ah.
What else?
The incidence of TCFA, thin cap, fibrotheroma, those particularly vulnerable plaques. Also the minimum lumen area, the vessel opening.
Right, the actual space for blood flow.
And they didn't just rely on imaging. They also took blood samples at baseline and 12 months.
To measure what?
Inflammatory biomarkers, things like hsCRP, IL-6, MPO myeloperoxidase, standard markers of systemic inflammation.
Okay, comprehensive. Methods seem solid. Let's get to the juicy part, the results. What did the OCT images show after 12 months? Especially that primary endpoint, the FCT.
That was quite striking. The colchicine group had a significantly greater increase in minimal FCT compared to the placebo group.
How significant? Do we have numbers?
Yeah, the average increase was about 87 micrometers in the colchicine group versus around 52 micrometers in the placebo group.
Right.
The p-value was 0.006, so statistically quite significant.
Wow, okay. So a measurable thickening of that cap with colchicine, that definitely suggests stabilization.
It strongly points that way, yes.
What about the other OCT findings? The lipid core, the inflammation.
Also significant changes there. Colchicine led to a significantly greater reduction in the average lipid arc compared to placebo.
So the fatty core actually shrank more.
It did. The reduction was about -36 degrees versus -25 degrees in the placebo group. Again, statistically significant.
Interesting. And the macrophages, the inflammation marker on OCT.
Same story. A significantly greater reduction in the mean angular extension of macrophages with colchicine. About -14 degrees versus -9 degrees. So less inflammation visible within the plaque itself.
So thicker cap, smaller lipid core, less inflammation, all pointing towards a more stable plaque.
That's the picture the OCT findings paint, yes.
Did everything change significantly? What about the lumen area, or TCFA?
No, not everything. There was no significant difference in the change in minimum lumen area between the groups.
So it didn't necessarily widen the artery overall.
Correct. And while the incidence of those high-risk TCFA plaques decreased in both groups, which you'd hope for with standard therapy, the difference between the colchicine and placebo groups wasn't statistically significant for TCFA reduction.
Okay, so the main action seems to be on the plaque composition and cap thickness, rather than vessel size or dramatically reducing existing TCFAs beyond standard care.
That seems to be the key takeaway from the imaging, yes.
Now, how did the blood tests line up? Did the systemic inflammation markers reflect these plaque changes?
They really did. It was quite consistent. Colchicine significantly reduced levels of hsCRP, IL-1RA, IL-18, IL-6, MPO, AZU1.
So lower inflammation systemically mirrored by lower inflammation seen directly in the plaque via OCT.
Exactly. It reinforces that anti-inflammatory mechanism is likely key here.
Did they look for direct links? Like, did people with the biggest drop in IL-6 also have the biggest plaque changes? Any correlations?
They did perform correlation analyses. They found, for instance, that the percentage increase in the fibrous cap thickness was negatively correlated with the percentage decrease in the lipid arc.
Meaning, as the cap got thicker, the lipid core tended to shrink.
Precisely. R value was negative 0.32. Significant.
Makes intuitive sense.
And they also found positive correlations between the change in lipid arc and changes in IL-6 and MPO.
So a greater reduction in lipid arc was linked to a greater reduction in those inflammatory markers.
Yes, exactly. It suggests, that the inflammation and the lipid component of the plaque are dynamically related, and colchicine impacts both.
Okay, that builds a strong mechanistic case. But the million-dollar question for clinicians is always about outcomes. Did fewer people have heart attacks or strokes?
Well, they looked at a composite endpoint, major adverse cardiovascular and cerebrovascular events, or MACCE. That included things like death, non-fatal MI, non-fatal stroke, revascularization.
And
numerically, the event rate was lower in the colchicine group, 11.5% versus 17.3% in the placebo group.
But
that difference wasn't statistically significant. The p-value was 0.4.
So a trend, maybe, but not definitive.
Right, and the authors themselves point out the study was really powered for the OCT endpoint, the FCT change, not for clinical events. 128 patients over 12 months is likely too small and too short to see a significant difference in MACE.
Okay, that's an important caveat. What about side effects? Colchicine can sometimes cause GI issues.
They tracked adverse events. Things like gastrointestinal symptoms and infections were reported, but importantly, there were no significant differences in how often these occurred between the colchicine and placebo groups.
So in this trial, at least, the 0.5 milligram dose seemed reasonably well tolerated.
It appeared so, yes.
All right, let's step back and think about the implications. For a cardiologist listening to this, managing ACS patients day to day, what's the main message from COLOCT?
I think the big takeaway is this. COLOCT provides direct visual evidence using OCT that adding low-dose colchicine to standard therapy can actually improve coronary plaque stability.
By doing what specifically?
By significantly increasing the fibrous cap thickness, reducing the lipid burden, and reducing macrophage infiltration, the inflammation within non-culprit plaques.
And this helps explain why we saw those event reductions in the larger outcome trials like COLOCT and LETIGO-2.
Exactly. It provides that mechanistic link. It supports the idea that colchicine's anti-inflammatory effects, maybe targeting neutrophils, maybe the NLRP3 inflammasome, translate into physically more stable plaques.
That makes sense. Did they notice if it worked better in certain patients?
There was an interesting subgroup analysis hint. It suggested maybe a greater benefit in terms of FCT increase in patients who already had their LDL cholesterol well controlled, like below 70 milli-DDL at baseline.
Really? So maybe it's particularly helpful for tackling that residual inflammatory risk even when lipids look good.
That's the implication, yeah. It suggests targeting inflammation remains important even when cholesterol is optimally managed. It's not just about LDL anymore.
That's a key point. Even with great statins, there's still risk, and inflammation seems to be a big part of it.
Absolutely. And while we still rely heavily on PCI for the culprit lesion in ACS, this study reminds us that non-culprit lesions are major drivers of future events.
And colchicine might help stabilize those other potentially risky plaques throughout the coronary tree.
That's the potential, yes.
Now, we should always be critical. What are the limitations we need to keep in mind here?
Well, as we mentioned, it's a relatively small sample size, only 128 patients.
Okay.
It was also a single-center study conducted in China, so Generalizability to other populations might be a question.
True. Anything else?
The biomarkers were only measured twice, baseline and 12 months, so we don't see the dynamic changes over time. And again, it wasn't powered for clinical events.
And they used simple randomization, not stratified for potential confounders.
Correct. All things to consider when interpreting the findings.
Definitely need more research, larger trials, diverse populations, longer follow-up.
Always. Science builds step by step.
So let's try to wrap this up. For our cardiology audience, the bottom line from this deep dive into COLOCT.
I'd say the core message is that this trial provides compelling OCT evidence that colchicine favorably impacts coronary plaque stability in ACS patients. We saw significant improvements in cap thickness, lipid arc, and macrophage infiltration.
Right. It really visually backs up the anti-inflammatory mechanism and its potential role in reducing cardiovascular events.
Precisely.
Okay, so here's a final thought to leave our listeners with. Considering these detailed insights, how might these findings, especially the plaque morphology changes, influence how you approach secondary prevention? Particularly maybe in those ACS patients who have good lipid control but still seem to have that persistent inflammatory risk.
Yeah, it really pushes us to think more about targeting inflammation alongside lipids, doesn't it? How do we best combine these strategies for optimal long-term outcomes?
Food for thought. It certainly opens up avenues for refining our approach. Thanks for breaking down this important study with us.
My pleasure. Fascinating stuff.